Good evening. Welcome to this group discussion on esophageal motility disorders. These are very difficult to understand, to be honest. I've been reading about it repeatedly, and each time there is a more complicated version of the same phenomenon. But while surgeons tend to ignore this because they're more interested in mechanical obstruction, if you look at the spectrum of esophageal disease which gives symptoms, motility disorders form a significant part. And so it is important for surgeons also to understand what these motility disorders are. I have tried to simplify the whole issue for you in this discussion. When we come out with answers, what I'm going to show you is going to be a simplified version. I'm only hoping that it's not too simplified a version, but it really is. If you look at certain of the classifications that are now available, the issue is really quite complex, but it can be simplified, and I hope what I'm going to give you will be perceived as such, as a simplified version, but nevertheless a very practical solution, because at the end of the day, whatever classifications, whatever stages, or whatever else you do in surgery, at the end of the day, it must help you as a clinician, as a surgeon, to take decisions when you have a patient, under your care. So group discussion, and I hope all of you have read up a little bit about it. And so let's go on and start off. I will call out the names, and you can unmute yourself and start answering. And let me see who else is. First, I must know who is on, so that who is SP, please? Can you unmute yourself and tell me who SP is?
It's me, sir, Sunil.
Sunil, okay, right, Sunil, fine, right, nice, okay. So let's start off with a very basic understanding. Ainas, what is a motility disorder? I'm not looking for any formal definitions and things like that. What is your understanding of the word motility disorder?
Basically, there is disruption in the movement or peristalsis, or like while during the passage of food, when there is a disruption in the peristalsis, is what we consider as motility disorder.
Yeah, I would agree, I would buy that, but to be a little more specific, it's not only peristalsis, any movement of the esophagus. And the other important thing is coordinated. That's another thing we must understand. Any coordinated movement that is dysfunctional will give you a motility disorder. Okay, it's as simple as that. It's a broad definition. A lot of things come under that. And I've really said broad categories. There are very many ways in which you can look at these disorders. Okay, a dysfunction of coordinated action can occur for many reasons, and they can be looked at different angles. So just guess a few angles that you can think of. Vinod?
Hello, sir.
Yeah.
Yeah, we can divide them based on pain, sir. Some painful and painless, and increase in more contractility and less contractility.
Okay.
And
as a clinician, what would you be interested in?
Clinically symptomatic patients, I'll be.
Okay. In symptomatic patients, if you want to study these problems and diagnose in a systematic manner, okay, in symptomatic patients, what would be the categories under which you would study them? Nikita?
Sir, hyper and hypomotility, sir.
Yeah, clinically I'm talking about. I mean, I agree. You can look at the motility and things like that, but clinically, if you are a clinician, you would like to know how it is affected, how the organ is affected, and then think of certain categories.
Can you go to the reflux and obstruction?
Obstruction and non-obstructive. That's one way of looking at reflux. Okay. Ainas, you were saying something?
Maybe neuromuscular involvement, like maybe patient has Parkinson's or
all of them are, right? By
yes,
definition, neuromuscular, when the coordinated movement is affected,
okay.
neuromuscular action is affected. That is given. So it's a difficult question. Yeah. So the issue is this: it may be either a primary disorder or a secondary disorder. Okay. Primary, the disease is in the esophagus itself. Please understand that coordinated action can be affected by pure neuromuscular phenomena. It could also be due to certain other issues which can affect the neuromuscular activity of the esophagus. Both of them come under this primary esophageal disorder. But you can have a systemic disease, which is called a secondary dysfunction. This is very important. It could be a tumor somewhere. It could be Chagas disease, a trypanosomal disease. It could be disseminated collagen disease like scleroderma and things like that. That can cause esophageal symptoms and cause neuromuscular abnormalities. So it's very obvious why we need this classification, because if it is esophageal, you must attack the esophagus. If it is systemic, probably a surgeon will have no role at all. And so you will have to deal with the systemic disease. That's one way of looking at it. Okay, so based on location, this is important clinically. And this is something which is not appreciated by very many people. Okay, by location, can you classify by location?
Oropharyngeal dysphagia and mid and lower esophagus.
Excellent, excellent. What do you think is more common?
Oropharyngeal dysphagia.
Yeah. What do you think we see more in the clinic as a surgeon?
Lower esophageal, sir.
Sorry?
Lower esophageal.
Lower esophageal. Very good. Sanya, can you attend to these disturbances, please? There's something happening. Yeah. Okay. Yeah. Okay. So that is very correct. That's very correct. So it's important to understand oropharyngeal and esophageal. Okay. And we as surgeons most of the time see esophageal, even though it is distinctly less common than the oropharyngeal. If you look at the total body of patients, deglutition and upper esophageal problems are a lot more common, maybe 70% of all disorders. But as surgeons, we do not deal with it directly. It's unusual. Maybe ENT surgeons deal with it, deal with some of them, but we don't deal with it, even though you must be aware of it. So I put it there, and we will learn a little bit about it. But the focus of this discussion is mostly on esophageal disease or lower esophageal symptoms. Why is it important to know this? Why do you need to know about motility disorders? If it's not directly surgical, if it is perhaps not, obstructive. Obstructive is something that surgeons like, in the sense that's their line. They want to know if it's a benign or a malignant stricture. You want to deal with it, but there is no obstruction in that sense. It's not a mechanical obstruction, but a functional one maybe. Why is it important to know? Samir, Samir, he has not opened his mouth. Yeah, go on. Samir, are you there?
Yes, sir.
Yeah.
So these patients, like they suffer from motility, like progressive dysphagia, and
I understand that, but why is it important to know about these disorders? I understand a surgeon said, I want to know about CA esophagus. I want to know about reflux stricture, but why motility disorder? I actually given you half the answer there. Vinod, you had started saying something.
To prevent unwanted surgery, sir. Something like a patient will come with symptoms of CERD.
Yeah. Okay, you probably wouldn't. Yeah, go on. Yeah. Anything else? Sanya, you want to have a guess?
So each of them is managed separately. So and since it is dysphagia being a little hampering to patients, the symptoms being hampering to them, to find out exactly what the cause is so that the treatment is specific.
Anything else?
Quality of life of the patient can be.
Yeah, indirectly you have said that. These are common. Understand? Patient doesn't come with you saying, I have motility disorder, I have CA esophagus, I have stricture. Okay, 20% of patients over 50 years of age, they come to you as a surgeon. So unless you know about it, you lose out on 1/5 of the patients, your patient population. Second, it can cause confusion in diagnosis. Even after many tests, sometimes there can be a confusion between a motility disorder and an organic or a mechanical disorder. But what is more important for all of us is to realize this, which is hardly ever realized by many of us. Just a motility disorder can cause all these problems: dehydration, malnutrition, choking, chest infection, aspiration, death, even death. Okay, chest infection, pneumonia, malnutrition. It really is something which is important. And so it is something that we must understand and bear in mind, even though we as surgeons look at mostly mechanical problems. Okay, so each of them has an etiological classification. The etiological classification for oropharyngeal is a little different from that for esophageal or lower esophageal. So can you think about oropharyngeal etiological classification? You know that. You know, are you there?
Hello, sir. Yes.
Yeah, go on. See, whenever you study something, I trust you guys have studied the books. It's all be given in the books. There's nothing new that I'm giving here. Of course, I read papers, not standard books, but even, you know, all these have these classifications. You must, you know, two things you must remember about any classification or any list. It must be categorized. You must be sub-classification, subheadings. And in that, as far as possible, put the commonest first and the least common last. That's a common rule for everything that you study and understand. Okay. So what is the etiological classification? It could be either neuromuscular or structural. Remember that both of them have a degree of neuromuscular element. Without it, there is no motility disorder. But here it is primarily neuromuscular. Stroke, Parkinson's, amyotrophic lateral sclerosis, things like this. These are upper esophageal. Structural is Zenker's. We all know about the cricopharyngeal spasm in this. And carcinoma can secondarily affect the neuromuscular function, even though it can affect it mechanically also. It can affect it secondarily neuromuscular function. There can be certain chemicals, you know, paraneoplastic syndromes, and also manifest as a neuromuscular disorder. This is for the oropharyngeal carcinoma. What about etiological classification for esophageal? Nikita?
Sir, neuromuscular and
Okay.
obstructive.
Okay. Tell me about it. Which ones are those? Give me examples. 2 examples for each in your view.
Sir, achalasia cardia would be neuromuscular, sir.
Mhm. Yeah.
And-
Okay. It's the same thing that we did. Primary is always slightly different for this. It is neuromuscular. Okay. Primary, otherwise called neuromuscular for esophageal. As you rightly said, achalasia, jackhammer, nutcracker, spasm, and hypertensive LES. These are the 5 common disorders that is recognized. It can be secondary. It's again neuromuscular in the basic etiological classification, basic etiology, but it's secondary. It's not, the disease is not per se in the esophagus only. It can be elsewhere and it will manifest, it will have esophageal manifestations as well. Okay. So if you have this kind of broad category in mind, then you'll be able to think of all the possibilities when you look at a patient. So basically in this discussion, we're going to deal with this the most. Okay. This group of things. I've mentioned the other things to let you know that these things exist, but clinically and in the subject of esophageal motility, this is the group of lesions that we have to focus on in today's discussion. Okay, Samir, there is something special about the esophageal muscle layer, say compared to the muscle layer of the stomach or the small intestine. What is it? It has a bearing on today's discussion. Everything that I say will have a bearing on the discussion. Ainas.
Sir,
So the myendric plexus is like between the circular and longitudinal muscle layer. You have the.
You have myendric plexus everywhere.
It is always. So like those ganglions are what is affected.
Ganglions are everywhere. I asked a specific question. How is esophageal muscle layer different from that of the stomach or the small intestine or the large intestine? They're all one group. Esophageal is something special.
So this circular muscles will be like a corkscrew, sir.
No?
Sir, striated
So like
muscles will be in
striated
the
and.
proximal portion.
Yeah.
Smooth
Praveen,
muscle in
you're
the distal
right.
portion.
Upper half is striated, which means that is the reason, things that hit the striated muscle activity, neural activity can affect that. Lower half is smooth muscle. And somewhere in the middle, there is an area of overlap. There's a transition between striated and smooth muscle, where in the certain part of the esophagus, not clearly defined in terms of anatomy, you'll have a combination of the both. There's a transition zone as well. So most of the upper esophageal issues can be attributed to striated muscle issues. Lower half is what we are discussing today involves mostly the smooth muscle. Okay, that is the peculiarity of the esophageal. Now, I'm again not going into the deglutition mechanism. It's a very complex thing. But if you again look at the major features, what are the two things that are, I'm asking you a very specific, two things that are important for smooth swallowing? And ignore the upper sphincter. I'm not interested because I told you I'm not dealing with it. For somebody to have a smooth, easy swallowing, what are the two main things that are required?
Peristalsis and relaxation of LES.
Excellent. Okay. If you understand this, gravity, of course, is important, but it is much less important. That's why I put it in small letters. So it's important to know that there must be a coordinated peristalsis and a coordinated or a synchronized relaxation of the LES. Without it, you cannot have smooth swallowing. Okay, that's an important thing because all of today's topic, all of today's conditions that we listed there earlier, all of them have some form of problem in either peristalsis or relaxation or both. If you understand this, you have understood today's class. Okay, that's all there is to it. This is what I said. I have simplified the whole thing for you. So at a neuromuscular level, there is a fundamental problem in most of these diseases. Ines, you had given the answer partially. You can give it completely now.
Sir, the inhibitory neurons are affected, sir, because of which there is the relaxation. There's improper relaxation of the muscle and sphincters which are involved, sir.
Okay. How does that come about? You're right.
So like it could be depending on the like in some cases there could be some circulating antibodies which is implicated
the antibodies affect what?
So
muscle fibers?
No, sir, the Orbax plexus, like the ganglion will be affected. Sir,
so the two things that happen is that the ganglion cells are affected and there is a degeneration of the post-ganglionic fibers. And you are very correct when you said that it is some kind of an immune process that seems to do it in genetically susceptible people. Okay. So this is what you have to understand. It is that there is some problem with the ganglion cells and there is also an associated degeneration of the post-ganglionic fibers. Okay, that's what causes this. That is the basic pathophysiology. Now, there is, as I said, the upper esophageal and lower esophageal issues are separate, not only in etiology, but also in symptomatology. So, Samir, have a guess. What do you think would be the common symptoms of the upper esophageal problems, oropharyngeal? Keep talking. If you're wrong, it's not an issue, but if you're silent, it is an issue. Okay, if you're silent also, it is not an issue. Ainas, go on, tell me.
More to liquids.
Big latency. Anyway, go ahead. Yeah, go on. More to liquids than to solids, correct? That's one of them for motility disorders. Yes.
And sir, undigested food will be regurgitated more.
Okay. If you can't swallow it, the upper, it's all common sense. You don't have to mug anything up. If you can't swallow something and it sort of hangs around in the oropharynx, okay, rather than get into the esophagus. Halitosis. No, because it doesn't stay there so long. Something is stuck there, where will it go? If you cannot swallow it, cannot go in, where else can it go? And what are its consequences?
Aspiration.
Yeah, okay. The important thing is you have cough, irritation of the larynx, you have aspiration, you have chest infection, nasal regurgitation. Blessed thing can come out through your nose. Okay, because of irritation of the voice box with the inflammation, you get a change in voice. But what is important is the last line. I think I'll ask Nitya to explain this. Localizing by the patient is not important, is what I've written. What do I mean by that, Nitya?
Sir, irrespective of where exactly is happening, the pathology is muscular. So it is not a structural abnormality. So it's a functional cause. So
No, I'm
local,
talking about the symptomatology, Nitya.
I'm not sure, sir.
Yeah. Sanya, you want to have a go at it?
That irrespective of wherever it is happening, the symptoms will be the same.
Where? So you're right, but where would
In
the
the
symptoms
oropharynx.
be? Correct. That's important. So by asking the patient, where do you feel the food being stuck? Where do you have the discomfort? Whether he says, when he says it's in the upper, in the oropharynx, it doesn't mean that the problem in the oropharynx. Even lower esophageal problems can sort of give them symptoms which is suggestive of upper esophageal issue. This is something that all of us must understand as clinicians. Localizing the level is not very important. This is in neuromuscular disease. Whereas in a mechanical disease like a stricture or a carcinoma, the patient will fairly accurately tell you where it gets stuck. So in the upper, in the neck level, mid esophageal level, lower esophageal level. In a mechanical problem, that is localizing is important. But in a neuromuscular issue like a motility disorder, it doesn't really tell you. Localizing is not important. Not that it is only in the upper esophagus. They may say I have a problem in the mid esophagus, but the problem may be elsewhere. So that is something which you must understand as clinicians. Okay, what about esophageal motility disorders? Praveen, what symptoms would they get?
So most common will be of heartburn, sir.
Yes.
Chest pain.
Chest pain. Okay.
Regurgitation and cough will be same.
Not that much, not as much as the oropharyngeal, but yes, chest pain. And this is something which you must understand. Samir, what is odynophagia? Ainas. Are you there? Not there? Nikita?
Painful swallowing, sir.
Painful swallowing, that's right. Okay, painful swallowing. Dysphagia is difficulty in swallowing, food getting stuck somewhere. Chest pain is chest pain all the time, whether you're eating or you're not eating. But odynophagia is pain when you're eating. That can happen. And some of the esophageal spasms that you get actually mimics MI, not uncommon. Okay, patient is so uncomfortable, comes out in a sweat, and you think the patient is having a heart attack, but it actually is a painful esophageal spasm. Okay. I'm sorry, I didn't introduce, I should have done. Sunil. Sunil is one of our participants today, and he's a surgeon from North Karnataka. He is spending some time with me learning laparoscopy. Okay. So I'm sorry about the digression, but I should have done it in the beginning of the class. Yeah. Okay. So as a clinician, when you see a patient with these set of symptoms, what should be your priority in management? When I say I'm not a trick question. I'm just saying what should go through your mind in terms of diagnosis and treatment or management of the patient. What should be the priority that you have to exercise? Nitya, can you tell me?
Sir, first of all, these patients present with heartburn. So we need to rule out cardiac. First thing is to rule out a cardiac pathology for the heartburn.
Okay, very good. What else? Thing is, Rule out secondary causes. Okay. Cardiac, definitely, you have to do that. But, and for anything is extra esophageal, which could be either cardiac or mediastinal. But what is more important, I told you about the primary and the secondary causes for neuromuscular disorders. You can't you cannot deal with secondary causes as a surgeon. So you must rule out these things. Okay. And of course, in esophageal disease, you must also look at the mechanical problems which we deal with as surgeons. You rule out these three things and only then you start seriously thinking about motility disorders. Okay. Because if you look at the seriousness of outcomes of all these diseases, these are the ones that are a lot more important than motility disorders. I did give you a list of all the problems that one may have, but that list is less important than the kind of problems people have because of secondary causes and mediastinal diseases and things like that. Okay. What would you focus on in physical examination? Vinod.
Sir, nutrition wise, sir, and patient is sleep
Very
cycle.
Good. Very good. Very
Is
good.
drowsy
Next.
or
okay.
And
you see, these are not trick questions. These are not questions that are designed to give you trouble. If I were your DNB examiner, this is all I would like to ask. Sanya, why do you think I asked this question? Can you think of why I would ask a thing like this? Focus. I ask for a focused physical examination. It is applicable to all diseases. Why would I ask for that?
I'm not sure, sir.
Nitya, you want to have a go?
To localize the pathology, sir.
You see, you're running an outpatient. I see all of you as consultant surgeons. Okay, if not today, tomorrow. You're sitting running a clinic and you have a patient coming with these kinds of set of symptoms. You do not, like in an examination, look at everything from top to bottom, like you report in an exam. Okay, but you have a focused clinical examination. And for that, you must know what you're looking for. Okay, so if I am looking for an esophageal cancer, for example, Vinod stopped with one list, nutritional status. I agree with that. What else would you look for in the abdomen and in the body, not just the abdomen? That's all I'm saying. That is the way you must think. Neck node. Okay. What else? It is not a problem to give this list, is it? Okay. It's just the way your orientation is. This is exactly what I do when I'm sitting in my clinic. Every day I probably examine my patients for 2 or 3 minutes, not more. But these are the things I focus. Nutritional status, functional status. If I have to intervene and do something, what is his functional status? Is he mobile in the house? Is he bedridden? Neck nodes, pleural effusion. Does he have a pleural disease or lung disease, mediastinal disease? Does given fluid? Epigastric mass? Is there a Uji junction carcinoma or some other mass? Liver, secondaries in the liver? Is there ascites? What else can you see in the clinical examination? Tell me. Nothing much. I could have added rectal examination and examination of the rectal shelf, which is again important, which is not added here. But I don't do a PR on every patient I see in the outpatient. That's why I didn't add this. But this is the way you do a focused clinical examination quickly and efficiently. I want you guys to think on those lines. That's very important. Okay. And priority wise, just give me a list of investigations that you would ask for if you see a patient. Let me tell you a patient who comes with a painful swallowing, feels some degree of regurgitation, as a bit of halitosis, and clinical examination, nothing significant. So what would be the investigations of choice? List it priority wise. Who? Vinod.
Sir, my investigations will be for the specific symptoms. I'll
list, yeah. Just list some investigations. Be specific in your answers. I've given you a pakka scenario, which is what you will do when you're a surgeon. Okay, I'm sitting in my clinic, I see these patients, I give you the clinical scenario. Now I tell my assistant, please write these investigations, or if I don't have an assistant, I'll write it myself. What would I write? That's all I want.
CBC and endoscopy.
Okay, list it, just list it, yeah. CBC and endoscopy, you would stop there.
Ultrasound, abdomen and pelvis.
Okay. What else? List priority wise. Okay. You got the right routine blood, not just CBC. You want to know perhaps the urea and creatinine and blood, blood sugar also. The patient is very cachectic. You may even ask for electrolytes. Ultrasound, barium swallow. Patient has come to you with dysphagia. Manometry, CCT, and I put question marks, PH studies. Okay. This would be the priority in which you do it. Now we'll need to go one by one and see what are, again, when I do all this, what are we must know how it is done and what we are looking for. So in routine bloods, what would you be looking for?
Sir, HB levels and
Yeah.
LFT.
Okay.
Albumin levels.
Albumin levels. Very good. All right. With kidney dehydration, creatinine there. And of course, I put in small letters extra esophageal cause. Any you can ask for anything that you want, LFT, CEA, blood gases, whatever. Huge list. We're not getting into it. We're looking at motility disorders. So per se, you're worried about anemia, hypoalbuminemia, and perhaps a compromised kidney function. What do you look for in endoscopy, Nikita?
So we'll be looking for any lower esophageal mass, sir, obstructive cause, secondary cause, or reflux disorders, or the
Good.
and
Good. Yeah.
mucosa status, sir.
Okay.
Esophageal mucosa.
Correct. We talked about achalasia, right?
Yes, sir.
So I agree about secondary causes.
Retention of
If
saliva.
it is saliva,
Gastric juices and saliva is
gastric juice, reflux is not a major feature.
residual food particles.
Yeah.
Stasis of food.
Yes, food stasis. Anything else? What would be the OG junction like in achalasia?
Tight junctions.
Tight junction. All right. Okay, that's sort of there, but you understand the trend that I am saying. Everything that you do as a surgeon must be like this. So when you ask for an UGI endoscopy, you don't routinely, you ask for it for the sake of asking for it. And if you're an endoscopist like myself, I actually, before I do the endoscopy, these are the things I have in mind. I'm focusing. If it is motility disorder, what do I find? If it's a mechanical problem, what do I find? And is it there or not? Now, that is the kind of focus that I have in my mind. And the chances of you are recognizing those things are much, much higher when you have such a focus. Okay. So if you have secondary causes, as I said, okay, you will expect a stricture, an inflammation, or an infection, or an extraneous pressure. But we're talking about motility disorders today. So there, the findings that you expect are dilatation, foot holdup, smooth, tight, smooth, it's not ulcerated, there's no exophytic lesion, it is smooth, and you have an abnormal segmentation. You wouldn't, if you do an endoscopy, you would not see peristalsis in any big way. But here you can get, in a hyperperistaltic esophagus, you can get abnormal segmentation. So these are the things that you look for. And I'll show you some typical pictures. Some of them are my own, some of them are borrowed. Okay. So this is a typical feature, how the food is, its esophagus is looking like a stomach, for example. Okay. And there's food holdup, and the OG junction per se is smooth. There is nothing wrong. There are a few endoscopic signs that have been described. Okay. But the common ones are these two. A rosette formation. You can see the OG junction where these kinds of lines, furrowed lines coming through, are called a rosette formation. Here, there is no depression of those lines. If it is deeper, it is called a rosette. If you have only a thin line coming without much of a depression, as it were, in those lines, it's called a pinstripe. These are the ones that you normally see. There are 2 or 3 more things that are described but not very evident. These 2 are pretty evident, and you clinically see them also reasonably often, okay, quite often. And this is classical hypersegmentation, called a nutcracker esophagus. We learn a little more about it as we go along. You can see how there is a whorl, as it were. Its muscles are hyper peristaltic or hypersegmented. Not even peristalsis is progressive. Here it is segmental. So you can have this kind of whorl-like appearance. Otherwise, it will be a smooth tube that you see when you normally endoscope. Okay, so these are the 2 main things that you look for when you are doing an endoscopy. In an ultrasound, what are you looking for? Quickly, Ainas.
So, like any other organ involvement, we look
Correct. At. Nothing, no motility disorder of the esophagus will give you anything in the abdomen. Okay, except this. You look for liver, masses, gastric wall, okay, and free fluid, ascites. This is the kind of broad kind of screening that you do with an ultrasound. I can't say it's a very, very important investigation primarily in motility disorders, but in secondary disorders, you should have that in mind. Radiology plays another important part. Okay, so Vinod, tell me, what is special about radiology when you're looking at motility disorders?
Barium swallow, sir.
Yeah, what is special about the barium swallow? Is it the barium swallow that they would do in any other case, like a barium meal follow through, or is there something special? Have you guys read today's topic?
Yes, sir.
Timed barium.
Sorry?
Timed barium esophagograms.
Timed baso. Fluoroscopy would do that, yeah. But anything special in the barium itself?
Tablets.
High density barium.
High density ginta, there's something else. Thick barium. Okay.
Yes.
Barium swallow that you do, barium meal follow through. That's a common old name. It's more liquidy. Here you can have a thick barium. Sometimes they can even dip a little cotton wool ball and then dip it in barium and then ask the person to swallow so that they can follow it better. And fluoroscopy is always better. Timed is one that Nitya said. She's not incorrect, she's correct. But even better nowadays is, instead of timed barium, do a fluoroscopy. You capture the whole thing in it's a cine radiography, as it were. And the patient is in a prone and right anterior oblique position. And you've got to give them about 5 or 6 swallows at intervals, not one swallow. And then do it repeatedly so that you get a pattern of what you see. Okay. So I'll show you some basic things here. This is a classical achalasia. So I want you guys to describe this. Anas, describe what you see.
So dilated esophagus with like the bird beak appearance, narrowing at the lower esophagus.
Smooth narrowing. And what else? You're right. What else is there? Only dilated, something else? Food hold up, no?
Yes, sir. Yes.
Can you see the layering kind of thing here? Can you see this is darker here?
Yes,
are you seeing my arrow? Lighter here. So this is a kind of layering of food that you see. Sometimes you can also have irregular mucosa because of the food particles that are stuck onto the mucosa. Okay. And what do you see on the right side photo radiograph? Anything special? I put it up specifically because there's one little area that may be doubtful. See, all this is dilated now. Look at this area. Can you comment on this area?
Irregular wall.
Irregular wall. There's a bit of a shouldering there, okay? So, but that is actually because the food stuck on it. But when you're looking at it, in a clinic, for example, you must have that in mind that we must check it again, okay? If you've already done an endoscopy first, you may want to endoscope them again, just to make sure that you've not missed something. If you have not done an endoscopy, when you do the endoscopy, if you see this first, when you do the endoscopy, you must focus on that area and see that there is no mucosal irregularity in that place. Okay, so I put this up. What is special about this? This is also achalasia.
Not a smooth tapering, sir.
It is smooth. That arrow is you can even see this, what you call the rosette formation, what you see as rosette formation on endoscopy looks like this, you can see little lines there.
Yes, sir.
Yeah, those are little barium in the furrows, but that is not, it's not shouldering or apple core appearance that you would see in a neoplasm. But what about the rest of the esophagus?
Sigmoid esophagus.
Sigmoid esophagus. That's it. It is so dilated and so tortuous that this is the one that is classically called the sigmoid esophagus, which is the final stage of achalasia. Okay, so here describe this picture. All right, Vinod.
Sir,
I've written the diagnosis, so
yes,
I just want you to, describe
dilated
it.
esophagus with corkscrew appearance.
Is it dilated necessarily?
Looks a bit dilated.
All
Not,
right.
yeah.
Yeah. Okay.
Corkscrew
Call it
appearance.
slightly dilated. Corkscrew. Describe the corkscrew appearance. The reason I'm asking you to do it is this is very commonly asked in your exams, and you guys really falter because you can't describe a picture that you see. And you must learn, practice and learn to describe a picture that you see. Use English words that describes this situation. Nikita, you want to have a go?
Sir, alternately contracted and relaxed pictures.
Okay, go on. What else? Just describe what you see. Okay, the way I would describe it, I see a barium filled esophagus, which shows particularly in the lower 2/3 an irregular tortuosity with areas which are contracted and other areas which are dilated, with no obvious mucosal irregularity and a smooth flow of barium into the stomach. Stomach is also delineated. Got that?
Yes, sir.
This is the kind of description that you give. Please practice this. When you see different pictures, practice describing what you see in simple English terms. And this can be, then end your, this can be typically called a corkscrew esophagus, which is seen in diffuse spasm or distal spasm of the esophagus. Okay, that's the description. So this is another thing that you look up to in radiology. And then we go on to the manometry. We told you that in esophageal motility disorders, the final arbiter of diagnosis, the gold standard, as it were, is the manometry. Okay, and understanding manometry is very difficult. I have simplified it, and I hope by the end of this discussion, we'll have understood it reasonably well. Okay, you must have proper catheters. The picture that you see on the right is a catheter with multiple holes and a transducer in each of those places. Usually done, the catheter is introduced in a sitting position, and positioning of the catheter is confirmed by radiology. Measurements are usually done in a supine position, but in the latest classification, there are separate standards for measurement in sitting position also. And the patient has 6 ml boluses of water repeatedly, and the pressure is measured at different levels. As I told you, the levels are decided both from radiology and the pressure. You first put the catheter into the stomach and pull it back, and then check the pressures, and you know where the LES area is, and then you can have graded distances proximal to the LES, and then measure the pressures. Okay, so what does a normal manometry? I'm not asking for pressure readings or the values, but what would you expect in a normal manometry? Let's ask the registrars. Nitya.
Sir, there are certain parameters that we measure, sir.
Yes.
Like the distal contractile integral and the
Go on.
Then there is IR, integrated relaxation pressure.
Correct.
Then
Okay.
distal.
You and I, very difficult to remember those. Okay. But it's important to know that those things exist. But in a normal manometry, remember what we talked about normal deglutition. What do you expect?
There should be relaxation, synchronized relaxation of the lower esophageal sphincter with which is corresponding with the peristalsis, the contraction activity.
So what is peristalsis to you? How do you describe peristalsis?
Manometrically, when the pressure increases, like when the transducer senses increase.
You're right. You're right, but you have not put it in the right words. There's a progressive wave of increased pressure going from the top end to the lower end and a synchronized relaxation of LES. Okay, you're spot on. That's the correct thing to do. You see, these are the positions of the catheters from LES here, there, and that several measures are done. But look what happened. This is the LES. Lower end is the LES. This is the upper end. As soon as the cricopharyngeal sphincter, upper sphincter relaxes and foot enters there, straight away the LES also starts relaxing. A few milliseconds later, the LES starts relaxing. And look at the peaks. As we progress down the line, the peaks are occurring more and more to the right, which means that there is a progressive increase in the pressure that keeps pushing the bolus down. And as the food enters at this point, LES has already relaxed and the food will enter into the stomach. This is the normal esophagus. So there's a peristaltic wave. There is a synchronized relaxation of LES. When there is problem in either of these, either peristalsis or relaxation of LES or both may be involved, then you have these different motility disorders. That's all there is to it. And I do not expect you to remember any of this, except remember that such things exist. Okay, IRP is integrated relaxation pressure. That is the LES relaxation. Distal contractile integral is a measure of the amplitude of the peristaltic wave. Contractile deceleration point, CFV. I won't explain all these things to you because you need to understand what they're measuring, and kind of mugging up the definition of these things are not important in my view. Okay, but mind you, in exams they may ask you and you better be prepared for it. At least before the exam, mug it up and go. Okay, so in the analysis, okay, I will go through it myself. All that you're looking at is the progress of the peristalsis, whether it is peristaltic or not. It may not be. If there is no coordinated progressive increase in the contractile pressure down the esophagus, then it is not a peristalsis. Okay, not only the progress, it would be a segmental contraction, which is not peristalsis. Not only is the progress, you also look at the amplitude of the contraction. There may be peristalsis, but the amplitude may be abnormally low or abnormally high. And the relaxation may or may not occur, or when it does occur, the timing may be inappropriate. So these are the parameters that you measure in the analysis of the manometry. Okay, and all these are given by one classification. All of you would have known about it, called the Chicago classification. And I'm not going to the details of this, and it is coming out in different versions. The current version is version 4. So, okay. Whom should we ask now? Nikita, if you read up about achalasia, manometry, what are the findings? What are the findings?
Sir, it classifies into 3 types, sir. Based on manometry only we can classify.
Good.
So in type 1, there is no peristalsis per se, sir. And the lower esophageal sphincter, the pressure is more is what it suggests. And in type 2, there is pan-esophageal, like one pressure gradient. The whole esophagus will be maintained at one single pressure.
Yeah. You're
and
right.
the low is sphincter is
Type
high,
3
sir.
is, yeah.
Type 3 is
See,
complete high pressure.
yeah. So you must understand that in achalasia, the common denominator is that LES is always high.
Yes, sir.
LES pressure is always high. What happens to the rest of the esophagus is what differs, okay? In type 1, there is no peristalsis. In type 2, compartmental pressurization. No peristalsis, but high pressure, high segmental pressure. And here it is high pressure all the way through. Okay? All the way through. It's a high pressure, but it's not segmental. It's not compartmentalization. And technically, for all the interventions that we do, type 2 has the best prognosis. Okay. It is also logical. You don't have to mug it up, because if you have very low pressure with no peristalsis, even if you correct the LES, food will not go down. There's no peristalsis. So relatively less useful than compartmental pressurization, when you can, with your myotomy, compartmentalized, with your myotomy, you can release that pressure. And so hopefully that this lack of peristalsis may get corrected. What was compartmental pressurization, hopefully it will become a proper peristalsis. When it is high pressure throughout the esophagus, as it is here, then you cannot surgically do the whole, you cannot do a whole myotomy for the whole esophagus. So then there is again a problem. So type 2 would give you the kind of best results that one expects. Okay. In others, in other conditions that we listed higher up, okay. Do you guys remember now what are non-achalasia problems of the esophagus, motility disorders?
Diffuse esophageal spasm, nutcracker syndrome, and
right. So what would you expect in those? Okay, distal esophageal spasm, high esophageal pressure. Okay, it will have a normal LES pressure and relaxation. All of them, all the others other than achalasia, you expect no problem with the LES. Okay, in nutcracker, also called hypercontractile, high esophageal pressure and LES pressure. Okay, pressure is high and relaxation per se may not be a problem in that. Okay, but pressure will be high. Now, Chicago classification does not recognize what is called nutcracker. It is still, according to version 4, this is an old term. You don't have to worry about it. I also didn't know until I did some reading just recently. And Chicago recognizes something called jackhammer esophagus, which has a high esophageal pressure and a normal LES pressure and IRP. IRP is, what is IRP, Ines?
Integrated relaxation.
Relaxation. Yeah. Okay. Relaxation is normal, but it has a high pressure. So you end up with a classical description. All these cannot be diagnosed with certainty without manometry. Okay, remember that. So when you're looking at motility disorder based on your barium swallow and your endoscopy, the next step for you, if the diagnosis is not completely clear, is a manometry. For example, in an achalasia cardia, okay, unless you're looking at something very academic, you do not really go in for manometry as a mandatory requirement. But if you are in an academic institution, you want to offer them the latest kind of tailored treatment, customized treatment, then you will have to consider a manometry. Okay. Now, why would you do CECT and pH studies? Vinod. (9:54). I better rush through. We are gone. Okay. This is like ultrasound. Okay. It's like ultrasound. You want to rule out secondary disease either in the chest or the abdomen. That's why you do it. Now, pH studies are a little more important, a little more interesting, tricky here. The reason is that some reflux, which is not obvious endoscopically, for example, it's actually a reflux disease, but you may not have esophagitis, you may not have ulcers. Okay, they may present initially as a spasm, and sometimes clinically you may have very genuine doubts as to whether it is a reflux problem or a motility problem. In that situation, pH studies will have to be done in addition to your motility problems. The reason is that even if you do a manometry, because of reflux, there may be a spasm. And then you really don't know whether it's because of reflux or not. And you have to differentiate, because if it's a reflux, you have to treat reflux. You cannot, if the spasm is secondary to reflux, what needs treatment is reflux and not the spasm. Because if you treat reflux, the spasm goes. So this is a very small subgroup of patients, but it is this subgroup of patients that you undertake pH studies. Okay, that is the indication for a pH study in a motility disorder. Now, give me the broad headings under which you can treat these patients. Samir, we'll get Samir, yeah.
Right.
Sir,
Baby of the class, yeah, go on.
sir, we'll first will try with the medical management, sir.
Okay. Give
For
me just the
academic-
headings. Give me just the headings.
Medical medical management.
Medical
then
or
poem, sir.
poem. Okay, endoscopic. Then
Endoscopic and balloon dilation, and
dilatation. That's also endoscopic, and
then finally surgical.
yeah. So what you must, when I say broad heading, always think of everything under broad headings. It is not just for writing answers or answering. Even in your clinic, when you're seeing a patient, you have to decide quickly whether you want to do medical management, endoscopic, or surgical management. Those are the ones. So then we go into each one of these. Okay. What is interesting is the concept of myotomy based on HRM. HRM is high resolution manometry. This is what I said. When you're giving customized treatment, okay, then you have to do manometry. And this is practically now followed by many centers undertaking POEM. Okay. And they do a manometry and they say, okay, there is a problem with dysphagia and chest pain, food holdup. Where is the pressure? Where is the holdup? At LES, at lower esophagus, or is it both? Is there a problem with both? And so what they do is, particularly while doing POEM, if it's only at LES, they do a limited myotomy. Okay, just 4 to 6 centimeters from the high, from the OG junction. If it is at the lower esophagus, which means higher than the LES, they can do a much longer myotomy. Okay, so that is the way that I wanted to bring in the concept of myotomy based on HRM, which is something which is happening in the last decade or so. Okay, so in a spastic esophagus, what can you give medicine wise? Ainas.
So, we can give antispasmodic agents,
Okay,
dicyclomine or like that.
that will probably help a little bit of pain. Okay, but what is the basic pathology there? It's a smooth muscle contraction, right?
Yes, sir.
So what can you give to relax the smooth muscle?
So nitrates can be used.
Correct. Correct.
And calcium channel blockers will
correct.
also.
Okay, that's what. Yeah, that's what I put it up there. I'm rushing through the last bit because it's already 10, I think 9:58. Yeah. Okay, but as I said, always treat reflux if it's present, because some of these spasms of esophagus are secondary to reflux. You can, if it's not a reflux, then you can use calcium channel blockers like nifedipine or nitrates. And in the last resort, not commonly done in very specialized centers, and I would not recommend it loosely. You can consider a long myotomy, which is almost always a POEM. It's not done surgically. Okay. So we come to the real problem, which is achalasia, which is the most common thing. Of course, I'm not belittling the other spastic disorders that we mentioned, but those are not easy to treat, and they're not primarily surgical diseases. Achalasia is, and it is quickly going out of the realm of surgical disease also nowadays with POEM and other alternatives that are coming in vogue. So how do you treat achalasia? Praveen, broad headings again, and then we look at each of those and their role. Samir himself mentioned some of these, yeah.
Sir,
Praveen not there, is he on call or something? Yes. Go on,
yes,
Nikita.
sir. Sir, pneumatic dilation, sir,
Yeah.
balloon dilatation,
Yeah.
and then endoscopic botulinum injection, sir,
Yes.
Botox injections, and
Yes.
laparoscopic myotomy or peroral poem, sir.
Correct. Pneumatic dilatation, Heller's myotomy or poem. Okay. Botulinum also is there. So I have put it in the next slide. What are the pros and cons of botulinum injection?
Down the line, after like few months, the effectivity
Recurrent.
of the botulinum decreases, sir.
Yes.
So it is used as a in the case where everything fails and the patient just requires only symptomatic relief, we can use it.
No, that's not the indication. The indication is if they cannot undertake, you cannot withstand anything else.
Anything else?
And
Yes.
patients who are very unfit for any intervention, okay, but you want to give them some symptomatic relief, you can give botulinum toxin. I've given you the dosage there. That's and I've given you the response rate here. These are all very well established data. Okay, 75% initial response comes down by half at around 6 months, and a good 1/3 of them need something else done, either repeat injections or some other procedure. So it's not the recommended treatment in people who are fit enough to have certain procedures. Okay, and the simplest of them is pneumatic dilatation. So what are the pluses and minuses of pneumatic dilatation? We know them.
Sir, it's something like a permanent technique, sir. There is
Okay.
a chance of recurrence will be less, and drawback is it is something like multiple sittings to be required.
If it is not, if you called it permanent, it's a very strong word and an incorrect word. But if it is permanent, why would you need repeat sittings?
It is something like a myotomy, sir, which is done in a. Chances of perforation will be high if you do at a single.
That is the downside. Okay. So you use endoscopic dilators. It may be 3-point graded dilators, they are called. Okay. There are two types of dilators. I usually use the direct vision one. It's called the Witzel dilator. It gets threaded on to the endoscope, and you can do a J and make sure that the position of the balloon is right. You can also have a fluoroscopic placement. Place it across the tight LES, achalasia. And you have what's called wasting. When you look at it, when you fill it up with fluid or air or whatever, there's a wasting where the achalasia, where the spasm is. And when you keep on expanding it, the wasting gets released. Okay. So I've just put some technical data as to how much you have to do and how long you have to do. But that's not the main thing. But the important thing is a good number get good results, but it's follow up for 1 point, paper suggests maybe 2 years, 1.5, 2 years, 2% perforation rate. And then because you have destroyed the LES, you have a 15 to 30% reflux rate. This is a problem with all achalasia procedures. Okay. There are some solutions to that and we'll discuss that. But so you must always remember perforation and reflux are the problems with anything that you do for achalasia. This is the classic balloon, which is fluoroscopically directed. You can see how the wasting is there at that point. And when the dilatation is complete, then the wasting goes. Okay, it becomes more dilated. This is a Witzel kind of, on direct vision dilator. So you've done a J maneuver. You're looking at yourself from within the stomach, and you can see that this balloon is in the stomach. And as you keep dilating it, what would have been narrow would have become bigger. So you can actually directly monitor the dilatation as you are dilating the balloon. So that is the pneumatic dilatation. I've done quite a few of these, and generally they work pretty well. Surgical cardiomyotomy can be, what are the kinds of myotomy historically that have been done? Nitya, you take the question.
Sir, I'm not sure about the old methods, sir.
Okay. Old or new? What are the things that are done?
Heller's cardiomyotomy is something I'm aware.
Okay. How can you do the Heller's cardiomyotomy?
Sir,
Everything is Heller's.
So basically, we can do it either open or laparoscopic
Right.
Heller's, and we basically cut the muscle fibers. At the first, we'll look at the
that doesn't, I'm
gastroesophageal.
not going into the technicalities of it. It's not the purpose of today. But you mentioned about open and laparoscopic. Okay,
Yes.
where do you open the body?
Upper midline incisions, sir.
Okay, your laparotomy.
Yep,
Is there any other approach to OG junction?
Thoracic.
Yeah, that's all. So people have done thoracotomy, they've done thoracoscopy, they've done laparotomy and laparoscopy. All these things can be done. Okay, that's the older methods were all this thoracotomy, thoracotomy and laparotomy were the older. The newer ones are thoracoscopy, but laparoscopy is much more common than thoracoscopy. Okay, and this is the important thing that I'm talking about. Okay, as I told you, even with cardiomyotomy, reflux is a significant issue. So to avoid reflux, you can either do either a DOR or a DOR is an anterior partial fundoplication. Toupee is a posterior fundoplication. Okay. We normally cut the esophagus, not the esophagus, the muscle, the LES, about 4 to 6 centimeters proximal to the OG junction and 2 centimeters on to the stomach beyond the OG junction. Okay, so usually we end up with a 6 or 8 centimeter separation on the anterior wall of the esophagus and the anterior wall of the stomach. So if I'm putting a partial fundoplication, should I prefer an anterior one or a posterior one? Both are described in the literature. Sanya.
Anterior only, sir.
Why? You're correct. Why? Nikita, you sort of unmuted yourself.
Yes,
You know the
sir.
answer?
I was about to tell anterior, it's modified Heller's myotomy I have
Yeah, why
mentioned.
do you prefer anterior as compared to posterior? That's all I'm asking. Think.
Because the release is happening.
Sorry?
Technically, it will be easy, sir. Anterior is already exposed to us. We did not dissect and.
Okay. You do not go around the esophagus. Okay, that's one of them, but there's something more important than that.
Crust of the diaphragm.
No. You see, you can protect your mucosal lines. You understand what I mean?
Yes, sir.
You have cut the muscle.
Yes, yes.
What if you inadvertently cut the mucosa? You should not have done. You can even check it and all that. But an extra layer of safety is this kind of. It's a serosal patch. Fundus of the stomach is brought on to the front of the esophagus, and that area where you have done the myotomy gets covered. Okay, those are the two advantages. And so I always do a DOR. I don't do a toupee at all. Long lasting, one of the longest lasting reported successes are in laparoscopic cardiomyotomy. Effect does decrease with time, but still it's never clinically all that significant. Works best in type 1 and type 2 achalasia. Reflux without your fundoplication is about 30%, and with your partial fundoplication is about 10%. Okay, and this is a classic thing. You split the muscle here and put the partial wrap on this side, so that you should not stitch these two. Having cut, you should not stitch these two. You cannot see this layer, this line of suturing that the surgeon would have done. It is covered by the stomach itself, but you stitch to this lip of your myotomy, the stomach, and then this stitch you put it on to this other side, you put it on to the right lip of your myotomy. So that is your surgical myotomy. Okay, and POEM is something which has now come. It's perhaps best in type 3 achalasia, because you can have a very long myotomy, but needs expert hands, not very easily available. Okay, its success rate in type 3 is better, has been shown to be better than in your standard Heller's operation. 40, this is actually, availability should have come here in, I suppose it could be either way. Okay, anyway, that's one of the questions that you need to know. Still, there is a 40% chance of reflux and 10% chance of adverse events, which is the same as in the laparoscopic Heller's. Okay, so this is the POEM that we do. You do a submucosal layer. You can see that The steps are very simple. Make a mucosal cut, develop a submucosal plane, do a myotomy. This length, as I told you, is decided by the high pressure zone that you see on the HRM, the high resolution manometry. And then after that is done, you put clips, as shown in this picture. You put clips to, can you see the clips? To cover the mucosal defect that you have created. Okay? But this is not very readily available. We are still in a stage where people are learning. They are still on a learning curve. And so at the moment, I'm not sending my patients for POEM as such, but I will probably be doing it very soon, once I know that some of the people I know are doing it on a regular basis. Okay. So in conclusion, it is important to have motility disorder as a differential in all patients with chest pain and dysphagia. Always rule out mechanical and inflammatory lesions, secondary causes. You have to consider manometry unless the diagnosis, for example, of achalasia is obvious on endoscopy and barium studies. And achalasia is best treated by laparoscopic Heller's myotomy and in POEM in selected cases when the facility is available. All right. I think that's my last slide. Questions and comments are welcome. Go on. Starting
Sir,
from the go on.
Sir, in case while we are doing a POEM and if it is or in case if you are doing numeric dilatation and if you are resulting in perforation, should we immediately take to the OT, sir, or we can just manage by this dilated tube only placing in the position, sir?
Yeah, you see, there are several caveats to that. One of the things you do is to get a gastrographian swallow first, and then see if it's a contained perforation that is within the mediastinum, or whether it has gone on to the pleural, it has breached the pleural membrane and gone on to the pleural cavity. If there is a free perforation, it is best to do a surgical exploration, drain it well. If it's a very minor perforation with very limited leak of the dye, you can give them high-end antibiotics. There are again gradations depending on how well the patient is. You can start with high-end antibiotics, NPO, IV fluids, 24 to 48 hours, see how he is doing, and then decide how you go further. And can even put a stent to, if it's a longer rent with a bigger involvement, you may even consider putting an endoscopic stent if the leak is limited. If the leak is significant, you need proper surgical drainage and rest to the esophagus, put a stent perhaps to cover the defect, a covered stent to cover the tear and maintain the nutrition of the patient. So it has to be tailored to the required to the patient's condition. Yeah. Am I clear or did I confuse you?
Yes, sir. Yes, I got it, sir. It's clear.
Okay. Anything else? Anas, your comment?
No, sir. Like, no, that's like I've understood everything, especially the manometry part, because it was very confusing when I
Okay. Last comments from our registrars. Nitya?
Sir, it was very concise and very nice class, sir.
Yeah.
And I have a doubt, like, are we supposed to interpret manometry values and come up with
I certainly don't interpret it myself. I don't think I'm even though I know the principles and I know the basics, I think interpretation needs a lot of expertise, and the guy who does the manometry should read it.
Okay, sir.
Yeah. Sanya? Sorry, I didn't see that Ravi Shankar had logged in. Yeah, Ravi, yours will be the last comment. Sanya, and after that, Ravi, please. Yeah.
It's a very nice class. A lot of doubts were clarified. Always confused with manometry, but now it was good.
All right. So all of you have said this, and I'm going to ask you these questions I'm going to ask you questions on this in a week's time. Let us see how much is retained. Okay. Okay. It also proves to me that I have also retained something. You know, I mean, I must say I had read these things even before because I was interested. And this is the kind of distillation of the ideas I've done. I'm sure the pure monometric specialists will call this an oversimplification. But I honestly believe that this is all we have to understand as surgeons, offering, proper surgical or whatever care, endoscopic care to our patients. Ravi, your final comments, please.
I think as usual, I think this is a sort of difficult and boring topic because you don't see much as far as the patient is concerned, a clinical examination apart from ruling out the obvious problems like metastasis or whatever. So it is a kind of an abstract problem, which I think, as you said, it takes a lot of difficult analysis to understand the problem, rule out the generalized problems like scleroderma and other things, and then cotton on to the surgical aspect which you are supposed to deal with. And as you said, now poem is taking away some of the things, but still I think the current data still suggests that LHM is still good in certain aspects and poem in other aspects. All of these things were well brought out. I think students need to go back and read, and repeat the questioning for at least 5-10 minutes may help. Thank you, sir.
All right. Thank you. Thank you and good night, everybody. Bye-bye.
Good night, sir.